नहीं आ रहा, बंद कर सकते हैं ऋतु, शेयर नहीं हो रहा मुझसे, नए सिरे से स्टार्ट करें।
हाँ, नो डाउट।
एक्चुअली फर्स्ट आई डिडंट ओपन द स्लाइड, मैंने बाद में खोली।
नो नो प्रॉब्लम, ये वाला मैं एडिट कर दूंगा, इस एडिट हो जाएगा।
I hope my slides are visible now.
Yes, the slides are visible. You can start.
Good day, friends, and warm welcome to this edition of Diabetes Essentials. Last week, we spoke about nephropathy or kidney disease. Today, we'll focus on a particular aspect of kidney disease, and that is microalbuminuria. But I just made a mistake. Microalbuminuria is micro in terms of definition, but certainly not micro in terms of clinical impact or public health impact. It has a mega or a macro impact on our health. And microalbuminuria is not just limited to kidney function or dysfunction. It has an impact over the entire endothelium, over the entire vascular system of the body. So let's see what microalbuminuria is. Microalbuminuria is defined as a level of albumin in urine, and the level is 30 to 300 milligrams per 24 hours. You can define microalbuminuria based upon a 24-hour urine collection, or even based upon a stat collection, a single time collection. You can also define it as albumin excreted in the urine, or as a urinary albumin to creatinine ratio, UACR. All these methods are okay to use. Most nephrologists prefer to use UACR these days. Sometimes we have to do a 24-hour urine collection, but in most people, you would be okay screening with a single collection. In general, irrespective of what definition we use, the definition of microalbuminuria is that it is the lowest detection limit of proteinuria measured by standard laboratory methods in the absence of urinary tract infection and acute illness. So if you found albuminuria in a patient or proteinuria, it will be significant only if there is no urinary tract infection or acute illness or perhaps bleeding in the urinary tract. Because if you have bacteria or pus cells or you have red blood cells in the urine, these will cause a false positive of proteinuria. If the level of protein excretion goes beyond 300 milligrams per 24 hours, then that is known as macroalbuminuria or overt albuminuria. This can be picked up with a classic dipstick, with a simple dipstick. You also have dipsticks to check for microalbuminuria, but they will be separate from the routine sticks that you are using for urine routine examination. There is also a difference between proteinuria and albuminuria. Proteins can be of many types. In the urine, albumin will comprise 20 to 70% of all total protein excreted. So when you're checking urine microalbumin or when you're checking albumin in the urine, rest assured that the stick you are using or the laboratory method will check only for albumin, not for other proteins. Why is it important to check for microalbuminuria? Because microalbuminuria is a marker of endothelial damage. Endothelium is the inner lining of all the vessels. Why is it that diabetes is a multi-systemic disease? Because diabetes is limited not only to the beta cell or to the islets of Langerhans or to the pancreas. Its impact is seen throughout the body from head to toe. When glucose circulates in the blood, it bathes the inner lining of all the vessels in the body, the arteries, the veins, the capillaries. All these vessels are lined with endothelium, and glucose acts like a poison or like a toxin upon the endothelium. When this toxicity becomes too much, the damage becomes too much, this endothelial damage becomes clinically significant. And Because this is a risk factor for vascular disease, both macro as well as microvascular disease. It is important to pick it up early. And microalbuminuria is one of the earliest ways of picking up endothelial dysfunction, even before the patient develops symptoms or signs. In the systemic calories and also in the glomeruli, in the endothelium, we have a glycocalyx, which forms a barrier to protein permeability. If this glycocalyx becomes damaged due to high levels of glucose or due to insulin resistance, if this glycocalyx becomes damaged, there is increased protein permeability. This permeability allows albumin to get excreted into the kidney, into the urine. So it's known as microalbuminuria to begin with. Later on, if we do not stop it initially, it will become macroalbuminuria. And this microalbuminuria is associated with endothelial and vascular and cardiovascular disease. The structural changes in the glomeruli do not correlate very well with microalbuminuria, but actually it is albuminuria which is more sensitive to all these damages. So you would really find that if you were to check microalbumin, that would give you a faster or a quicker idea of kidney damage as compared to any structural tests that you would do. And it is this permeability which begins what we call a vicious cycle. Once the glomerular capillaries become permeable to protein, albumin begins to leak out, that is microalbuminuria. Once this begins, a vicious cycle of toxicity starts. In the glomeruli, you begin to develop glomerular hypertension. This becomes associated with systemic hypertension and also with increased cardiovascular risk. So in everybody with diabetes, we should actually check for urine microalbumin at least once a year. But whenever you're checking for urine microalbumin, especially from an Indian perspective, do rule out urinary tract infection, genital tract infection, and urine RBCs or hematuria. If you're checking microalbumin in a lady, ensure that she is not menstruating or she has not stopped menstruating in the past 1 or 2 days. These simple tests, these simple caveats will help us prevent a lot of overdiagnosis and unnecessary stress. If microalbumin is high, then you may want to monitor twice a year as well. And if microalbumin continues to worsen, then what it means is that our risk is great, our prognosis is poor, but don't get depressed. All it means is that we have to become more aggressive in therapy. The good thing is now that we have lots and lots of drugs which we can use to prevent worsening of normo to microalbuminuria, of micro to macroalbuminuria. And we can also use these drugs to reverse the condition. We can reverse macro to microalbuminuria and micro to normoalbuminuria. So actually there is a lot that can be done. But the first thing, like I said, we have to do is we have to screen our patients. And when you're screening, make sure that there's no infection, no obstruction, or no bleeding. If you found microalbuminuria, then you have to treat. So in the field of prevention, we speak of primary, secondary, tertiary prevention. We'll also talk about quaternary and quinary prevention. Primary prevention means the risk factor is there, that is diabetes mellitus. I want to prevent onset of microalbuminuria. So I will use the best drugs to control blood pressure and glucose. I will preferentially use an ACE inhibitor, and I can also use an SGLT2 inhibitor or a GLP-1 receptor agonist. Suppose my patient has developed microalbuminuria, then I would still want to practice secondary prevention. My patient has endothelial damage, but I want to prevent diabetic nephropathy. I want to prevent the onset of chronic kidney disease or significant chronic kidney disease. I will continue to offer glucose control and blood pressure control to the patient, but the best drugs here would be an ACE inhibitor or an ARB. For glucose control, again, we will become more aggressive. We will prefer to use an SGLT2 inhibitor followed by a GLP-1 receptor agonist. Metformin is safe in such patients. Now, supposing our patient developed chronic kidney disease, stage 2 or 3, we still have to keep on working. Here it's here what we are doing is tertiary prevention. We want to prevent CKD stage 5. We will use higher doses of ACE inhibitor or ARB, ensure good blood pressure control, be watchful for electrolyte dysfunction, especially for hyperkalemia. We will use the SGLT2 inhibitors up till an EGFR of 30, liraglutide up till an EGFR of 15, and very safely we can use insulin for glucose control. There are two other terms used in the field of prevention. These are quaternary and quinary prevention. Quaternary prevention enjoins us to avoid over-diagnosis, over-labeling, and over-treatment. So do only those investigations which are necessary. If your patient has got diabetic kidney disease, label as such. If your patient has got non-diabetic kidney disease, ensure that you have not given the wrong label. And don't over-treat. Quinary prevention is very important. This is important from our point of view, your point of view, my point of view. Quinary prevention requests us to prevent misinformation and promote the right information regarding diabetes management. So we are in this era of social media, where everybody on social media has his or her own opinion, which may be correct, which may be wrong. So when people will come and say, do not take an antihypertensive drug because it causes kidney disease, nothing can be further from the truth. Antihypertensive drugs are actually there to prevent kidney disease. If somebody says, my relative took insulin and then the kidneys got spoiled, actually that's wrong. The kidneys were spoiled earlier, insulin was taken too late, it should have been taken earlier. So when we handle this, this is quinary prevention. If you have a patient with microalbuminuria, what should you do? Such a patient is a high-risk patient for us. Take it like an anginal equivalent or a myocardial infarction risk. Manage all the risk factors for CV disease. What are these factors? A is for adiposity. Ensure good body weight. B is for blood pressure. Bring the BP down to 130/80 or below. Use ACE inhibitor ARB. But remember that usually monotherapy will not work. You will usually have to add either a diuretic or a calcium channel blocker. In 2/3 of all patients in my practice, dual therapy will be needed. In about 25%, monotherapy may work, and in 15%, you will need 3 or more than 3 drugs. So if it is a dual therapy, either we can give ACE inhibitor ARB plus amlodipine, or we can give ACE inhibitor ARB plus hydrochlorothiazide or chlorthalidone. These are my common combinations. If it doesn't work, a triple therapy will be in order. That will be ACE inhibitor or ARB plus calcium channel blocker plus diuretic. A for adiposity, B for blood pressure, C for cholesterol. Actually, in chronic kidney disease, the recommendations are you don't even need to check the lipid profile. You can start cholesterol lowering therapy, statin, without testing. But still, it would be a good idea to do a lipid profile first. And D is for diabetes. Good glucose control is required. Apart from that, stopping tobacco is mandatory. You have to counsel the patient very clearly. In endocrine practice, kidney disease and thyroid eye disease, these are two diseases where we are very firm with the patient about stopping tobacco. Of course, in internal medicine, many other issues are there like asthma, COPD, malignancy, where tobacco cessation is mandatory, but kidney disease does rank among them. We spoke of managing adiposity, blood pressure, cholesterol, and diabetes, and then preventing substance abuse. In the diabetes field, now gradually the drugs of choice are changing. Over the past few months, we have discussed all these drugs. If you have a patient with microalbuminuria, it would be a good idea to start SGLT2 inhibitor over and on top of metformin. Other drugs which are proven by evidence to reduce albuminuria, to reverse albuminuria, include linagliptin, which is a DPP4 inhibitor, and glyclazide XR, which is a sulfonylurea. You can use all these three in combination with metformin. But in general, if 3 drugs are not working, then it would be a good idea to start insulin. Metformin is safe up till an EGFR of 30 and above. If your patient is very cachexic, not eating properly, your patient has got reduced appetite, reduced absorption, lot of weight loss, then insulin would be the drug of choice. You can stop metformin for some time. In general, in the OPD, microalbuminuria will be present in nearly 1/3 of all your diabetic patients. Screen them regularly, treat this as a risk factor, and use that albumin number to motivate your patient to take therapy. So let's say you're writing an SGLT2 inhibitor or a GLP-1 RA or insulin, and your patient complains, why are you giving such a medicine, such an expensive medicine? The answer is, we are giving this medicine to you not only for glucose control, but also to protect your kidney and to promote longevity of your kidney. This microalbumin that you see, it's not a disease in itself, but it is a risk factor for other diseases, and we would like to prevent these diseases from occurring. We would want you to live a hale and hearty life. So microalbumin is something that I do use in my clinic as a motivational tool as well. We call it a theranostic tool. It is diagnostic and it is therapeutic because it encourages my patient to take the appropriate therapy. Let's come to our questions of last week. Last week, one question was, what are the benefits of using an insulin pump? And this is not the right answer. Insulin pumps do not help with weight loss. The other question was, what are the sources of fluid gain? And the answer is all of the following: excessive IV fluid, excessive sodium intake. Sodium causes water retention. You will find many people who are salt sensitive. The moment they stop taking salt, their blood pressure disappears and their edema disappears. Another source of fluid gain would be reduced inotropy or for example, congestive cardiac failure and also renal disease. We'll have the questions for this week now, and then we'll take questions. As always, it's a great pleasure being with all of you. I really enjoy being on this journey of diabetes control across India. Many times we face a lot of compassion fatigue in our practice. We get tired. But what do we learn from Urdu? Jazba, Josh, Junoon. In simple English, passion. If you have the Jazba, the Josh, and the Junoon to manage diabetes, certainly we will win the fight against diabetes. जो जीने की जंग है या डायबिटीज की जंग है, वो हम जीत के दिखाएंगे. So डर के आगे जीत है. That is a famous Indian advertisement that we know. But here, microalbuminuria के आगे जीत है. Because microalbuminuria tells us that there is endothelial dysfunction. It also tells us that we have a window of opportunity in which to intervene. And that's what we are all doing with each other when we learn about the latest medication, the latest lifestyle changes to advise our patients. Thank you and Jai Hind.